What's really concerning is the vast spectrum of symptoms that fluctuate over time.
I never thought I would have 7 months of my life wiped out by this virus. It's just gone, evaporated.
The take-home message is that it's important for governments and citizens to keep focused on breaking the chains of transmission.
Everyone is responsible for this, from presidents to people on the street. We are all part of the information society. It is our responsibility to ensure that we pass on good information to others.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.
Hello everybody, I am Fadela Shaib speaking to you from WHO headquarters in Geneva and welcoming you to our global COVID-19 press conference today, Friday, 30 October. Present in the room, as usual, is the WHO Director General, Dr. Tedros. Joining him is Dr. Mike Ryan, Executive Director, Health Emergencies, Dr. Maria von Kerkhoff, Technical Lead for COVID-19, Dr. Janet Diaz, Team Lead Clinical Care for COVID-19, and we will also be joined by Dr. Jawad Mahjour, Assistant Director General Emergency Preparedness. Dr. Soumya Swaminathan, Chief Scientist, will join us shortly. We have in the room also Dr. Mariangela Simao, Assistant Director General, Access to Medicines and Health Products, and Dr. Bruce Aylward, Senior Advisor to the DG, who leads the ACT Accelerator. Welcome all. We are also joined remotely by Professor Didier Houssin, who will respond to your question on the Emergency Committee on COVID-19. Welcome, Professor Houssin. We have simultaneous interpretation in 6 official languages, plus Portuguese and Hindi. Now, without further ado, I will hand over to Dr. Tedros for his opening remarks, and Dr. Tedros will also introduce our guest. Dr. Tedros, you have the floor.
Thank you, Fadila. Good morning, good afternoon, and good evening. I want to start by noting that WHO is closely following the unfolding situation in Greece and Turkey after the earthquake today. We will work with the 2 countries to ensure that emergency medical care is provided for those in need. Our thoughts are with all those affected. Over the past few months, I have heard firsthand from people who face mid to long-term effects of COVID-19 infection. What's really concerning is the vast spectrum of symptoms that fluctuate over time, often overlap and can affect any system in the body, from fatigue, a cough and shortness of breath, to inflammation and injury of major organs, including the lungs and heart, and even neurological and psychological effects. Although we are still learning about the virus, what's clear is that this is not just a virus that kills people. To a significant number of people, this virus poses a range of serious long-term effects. While people do recover, it can be slow, sometimes weeks or months, and it's not always a linear route to recovery. Though exact numbers of people experiencing the long-term effects are not yet clearly defined, post-COVID-19 symptoms and complications have been reported in both non-hospitalized and hospitalized patients. There have been cases in women and men, both young and old, and even in children. WHO will continue to do more research to establish best standards of care to accelerate recovery and prevent such complications. It's imperative that governments recognize the long-term effects of COVID-19 and also ensure access to health services to all of these patients. This includes primary health care and, when needed, specialty care and rehabilitation. I would now like to hand over the floor to 3 patients who are still combating the long-term effects of COVID-19 so that we can hear their stories. First, Professor Paul Garner from Liverpool School of Tropical Medicine, who has himself been recovering from COVID-19 since March. Paul, the floor is yours.
Thank you, sir. It's a great honor to join you. I respect your leadership and your organization's pivotal role in this pandemic. I'm an infectious disease epidemiologist. I helped set up Cochrane, and I work with you in guidelines in infectious diseases. I became unwell in March. I was fit and well, and I assumed that this COVID illness would be, I'd be able to brush it off my shoulder. For 4 months, I went through cyclical bouts of dreadful fatigue, sweats, headaches, unable to move, mood swings, and that went on for 4 months. And then I had another 3 months completely exhausted. When I overdid things, the illness would echo back, it would come back, and it was completely unpredictable. And for the last 2 weeks, things have been improving, and I'm beginning to get my sense of humor back, and I'm beginning to take gentle exercise. I never thought I would have 7 months of my life wiped out by this virus. It's just gone, evaporated. So, as you have said, sir, long COVID is a huge array of symptoms. I have one particular form. Others have damage to the heart, persistent breathlessness, problems thinking, and other evidence of organ damage. Can you hear me okay? Does it sound
yes,
okay?
Very clear. Please, go
okay.
on.
Yeah, sorry, it just, and other, so, but we must remember, post-viral syndromes are not new, but what we have here is just a huge scale of people that are suddenly severely disabled, wide variety of people that have never experienced long illness, with a level of disability that hasn't been seen this century. Last century it was seen with the world wars only, and it affects everybody: drivers, people working in restaurants, building sites, hospital porters, doctors. Everybody and everywhere is getting this. So I would just like to say that I respect that WHO recognize this. This is very important. Health professionals, families, and patients need to know it exists, that it has many faces, and it isn't in your head. Employers and society need to accommodate this, and we need, as you say, sir, sensible, supportive primary health services to help people convalesce and get better. Thank you for asking me to join you today.
Thank you so much, Professor Garner, for sharing your experience. And now to Martha Sibanda, a nurse who is joining us from Johannesburg, South Africa. Martha, the floor is yours.
Good evening. My name is Martha Sibanda. I'm a nursing sister at the Charlotte Maxeke Johannesburg Academic Hospital. I started getting symptoms on the last week of June. One of them being shortness of breath and fatigue most of the time, and coughing, a little bit of a productive cough. So by the end of June, I was so sick, I got admitted at the same hospital that I work at. I was on oxygen because I couldn't breathe because of the shortness of breath. And then 3 days later, I tested, and then they came back, my results came back positive. 3 days later, I was taken to ICU because I was very hypoxic. I was put on high flow oxygen. I stayed in ICU for 8 days, 8 solid days. I did very well. They weaned me off daily on oxygen. And then on the 8th day, I was taken back to the ward, still on oxygen, on 3 liters per minute on nasal cannula. But the problem was that it wasn't easy to be weaned off the oxygen. I stayed on oxygen until the day I was discharged, which was 26 days later. At the moment, I'm still struggling with shortness of breath, even though this is my 4th month, because initially I got sick, it was June, now we are in October. So 4 months, I still struggle with shortness of breath. I haven't been back to work, I'm still at home, but I'm looking forward to going back to work sometime end of November, hoping that slowly I'll manage to breathe by myself without oxygen. And I also would like to emphasize the care that I got from my hospital. The ICU staff were very excellent. They were hands-on, and the staff in the ward were also excellent. I think I survived because of the teamwork of both the ICU and the ward. Thank you very much for inviting me to your conference today.
Thank you, Martha, for taking the time to share your experience with us. I would now like to hear from Lith Hishme from the United Kingdom. Lith is a member of the Long COVID SOS, a patient advocacy group in the United Kingdom. You have the floor, sir.
Hello again, Dr. Tedros. My name is Laith Hishme. I'm 26 and I'm from the UK. I'm a member of Long COVID SOS, a group set up to advocate for patients of long COVID here in the UK. I caught COVID on the 13th of March. I was at work and it started with just normal flu-like symptoms, a sore throat, a cough. And at the time I wasn't even sure it was COVID. I went home and over the next 2 weeks, the symptoms started to develop slowly. I developed a fever, slight cough, shortness of breath, and just your typical flu-like symptoms. And then that started to get worse until it developed into full-on delirium at some point. But after that, I was fine for about a week. And I decided to leave and go get groceries as I thought I'd recovered. And so I could go and end my period of self-isolation at the time. When I got to the shop, I developed shortness of breath. My heart started racing, and I went through something I'd never gone through before. Being 26 and fitting well before that, I'd never gone through anything like that, and I was terrified. I ran out to the street. I flagged down a police car, and an ambulance was called. They arrived. I could not get up at the time, so they checked my vitals and they loaded me into the ambulance and took me straight to A&E. At the time in the UK, COVID testing wasn't widespread, so they did a long ultrasound of me because I was suspected of having COVID, and it showed the end stages of pneumonia. And the doctor diagnosed COVID-19 at the time, but he said I should be fine because it was the end of it. He didn't see anything concerning at the time. And unfortunately, he was very wrong. And it's been 8 months, almost 8 months now, and I'm still suffering from fatigue, brain fog, chest pain, heart palpitations, digestive issues, short-term memory loss. It's just, there is no system in my body that hasn't been affected. And if you'd asked me 8 months ago if I thought that this would happen, if I'd caught COVID, I would have said no, not at all. I looked at the statistics and I thought, I'm probably going to be fine. It'll be, flu-like, it'll be mild, 2 weeks and I'll be fine, but that has not been the case. I've been off work for the last few months. I went back to work on reduced hours, but I couldn't even cope with that because of the brain fog. I used to be a software engineer, and now I can't do that. I also used to do research into artificial intelligence, and now I can't do that either. I want my mental abilities back, that's all. Thank you.
Thank you, Light. Listening to Paul, Martha, and Light share their experiences and array of symptoms, It really reinforces what a dangerous virus COVID-19 is. Your stories underscore that those facing the long-term effects of the virus must be given the long time and care they need to recover fully. It also reinforces to me just how morally unconscionable and unfeasible the so-called natural herd immunity strategy is. Not only would it lead to millions more unnecessary deaths, it would also lead to a significant number of people facing a long road to full recovery. Herd immunity is only possible with safe and effective vaccines that are distributed equitably around the world. And until we have a vaccine, governments and people must do all that they can to suppress transmission, which is the best way to prevent these post-COVID long-term consequences. In that vein, the Emergency Committee on COVID-19 has just concluded a two-day meeting where they discussed the way forward. With global cases continuing to rise and some countries going in the wrong direction, the group has made a series of recommendations for WHO and member states to act on. The take-home message is that it's important for governments and citizens to keep focused on breaking the chains of transmission. Governments should focus on tackling the virus and avoid politicization. No matter where they are in terms of the outbreak, they should keep investing in the health system and workforce and improving testing, tracing, and treatment of all cases. And there is light at the end of the tunnel. As well as rapid tests and dexamethasone, several vaccines are now in final phase 3 trials. If proved safe and effective, they will be rolled out through the ACT Accelerator's vaccine arm, the COVAX facility, which is now supported by 186 countries. I thank Lebanon and Botswana for joining recently. The committee recommended that to prepare for new COVID-19 vaccines, WHO and governments must work closely to develop rollout strategies, train health workers, and ensure clear communications with the general public about vaccination. Just as we look forward with hope, WHO continues to work to establish the origins of the virus to prevent future outbreaks. Today, a group of international experts had their first virtual meeting with their Chinese counterparts. I joined to thank them and offer any and all support to ensure the success of their ongoing research. From the long-term effects of COVID-19 to breaking the chains of transmission to establishing the origins of the virus, WHO will continue to work in partnership across the world to drive science, solutions, and solidarity. I thank you.
Thank you, Dr. Tedros. We will now open the floor to questions from journalists. I remind you that you need to raise your hand, use the raise your hand icon in order to get in the queue to ask your question. Let's start with Christophe Vogt from Agence France-Presse. Christophe, can you hear me?
Yes, hi, I can hear you very well. Thank you for taking my question. It was about the new measures that have been announced in France on kids wearing masks. France asks now that masks are worn started at age 6. The thing is that it seems that all over the world there are different rules, different people saying different things about what time and what age kids should wear masks. So I was wondering if you could give us an assessment and if there is any hard science or new hard science about how infectious kids can be, and are they the super spreaders that has been recently raised in, I think, in the New York Times article. Thank you.
Thank you, Christophe. I would like to invite Dr. Van Kerkhoff to take this question. Thank you.
Thank you, Christophe, for the question. So I'll start with the second part of your question, then go to the first part of that. So with regards to COVID-19 in children, we are tracking mainly three things, among many others. Looking first at the severity and the disease that's caused in children. And luckily, for the most part, children who are infected with the SARS-CoV-2 virus, the virus that causes COVID-19, tend to have more mild disease, and many are asymptomatic. This is not universal, though. There are some children who have developed severe disease, and there are some children who have died from infection. We are also looking at the extent of infection in children, because in many parts of the world, children are not tested. And so it's very difficult to understand how many children are infected through current surveillance systems, which is looking for using PCR testing to find acute infection right now. There are seroprevalence studies that are conducted which looks at the antibody response among individuals who are sampled. And when we look at children, there are a few studies that have been done and more that are underway. And there are differences in the rates of infection among the youngest children versus adolescents. And there tend to be less seroprevalence, less evidence of infection measured by antibodies in the youngest children compared to adolescents, teens, as it relates compared to adults. The third thing that we look at is transmission. And the rates of transmission either between children or from adults to children and from children to adults. And there are many studies that have been underway. Most of these are looking at household transmission, which tend to start with an infected, symptomatic adult, and then looking at if transmission has occurred to children or the other way around. And we know that children can transmit the virus. Again, there does seem to be some difference by age group, with the youngest children transmitting less than adolescents. And that makes sense if you think of the type of interactions that children have. So to summarize, we know that children can be infected. Most of them have mild disease, many have asymptomatic, but they can be infected and they can transmit. And so what we use that information to help us better understand, the extent of what is happening within children as schools open up, of course, because we all recognize the incredible importance of having children in school, not just for educational benefit, but for many other benefits. WHO has issued guidance on the use of masks in children recently, a few months ago, I think. And what we do is we break down our recommendations by age. First of all, masks must be part of a comprehensive strategy. For all age groups, masks alone cannot be used alone. They have to be used with physical distancing. They have to be used with hand hygiene. They have to be worn appropriately, put on and taken off appropriately with the right hand hygiene. They need to be used with all of the other measures that are in place. But for children, what we recommend is under 6 years old, so 5 and under, we don't recommend the use of masks for many reasons, because of the way the children are developing, the adherence to wearing them, many reasons. For between 6 and 11 years old, we recommend taking a risk-based approach, depending on where the children are, the type of activities the children are in, if they can be monitored, because of course if you're wearing a mask, there are some risks associated with wearing a mask, so they need to be worn safely. And then 12 and over, we recommend the same recommendations as adults. So we have outlined that. We do have some guidance around the considerations when taking those decisions for the use of masks in children. But again, masks must be used as part of a comprehensive strategy.
Thank you. I would like now to invite Simon Ateba from Today News Africa to ask the next question. I would like also to remind journalists that our guests and Professor Didier Houssin are online if you want to ask them any question. Simon, you have the floor.
Yeah, thank you for taking my question. This is Simon Ateba from Today News Africa in Washington, D.C. The US has now surpassed 9 million cases overall. And we know that a report recently cited President Trump as one of the biggest sources of misinformation on COVID-19. His push, miracle cure, hydroxychloroquine, and all the rest. I was wondering, does the WHO have a game plan to stop misinformation from someone as powerful as the American president? And also, the second part of the question has to do with the US election. We've seen how people have been able to vote safely, with almost 90 million people who have voted so far. is that the way to go? Like, do you recommend that government have early voting in all the states to avoid all the people trooping at polling unit at the same time? Thank you.
Thank you, Simon. Dr. Ryan?
Yes. Yeah, with regard to, there's two parts to your question, Simon. With regard to voting, we've been working with many authorities around the world in providing risk management advice for when they have decided to carry out elections and how to manage the face-to-face or in-person voting in the safest way possible. Clearly, many governments have made different decisions. Some have postponed, some have created a mixture of in-person versus remote voting or absentee voting, and some have gone for in-person voting exclusively. This is, to a great extent, has depended upon logistics, on technologies available, on the background incidence of disease in that country. And again, like with travel, like with schools, these are all contextually driven decisions based on how much disease there is, what the available resources are to deal with that, and how much the activity is needed against how much can be invested to make them safer. And this is no matter what endeavour we undertake in our society now, each and every time we have any moment when people come together in large groups, we have to decide on whether or not such events should go ahead, and then if they need to go ahead, how they can be de-risked, or whether we can do risk management measures to reduce the risk to the absolute minimum. You mentioned the US early voting at the moment, and certainly we are not there, but from what we observe, the early voting process seems to have been undertaken with great care, with a lot of planning in terms of physical distance, wearing of masks, and special training of the people working in those centres. We have no data other than our own observations, but certainly it would appear that that process has been managed very, very well. And as the first part of your question relating to information, misinformation and disinformation, WHO works very, very hard, and in fact in this pandemic have never worked harder with external partners, both in terms of community level partners, governments, the tech industry, to really deal with issues around misinformation and disinformation. We focus on trying to get the best information out there, getting verified, truthful, good information to people as quickly as we can. That has been the focus, but we are aware that misinformation can lead people to be confused and not to fully understand and being able to implement. It's very important if our populations are to take action. Information and knowledge don't automatically drive action. Conflicting information and conflicting stories will definitely not lead to the proper action. It is difficult enough with good information to generate the appropriate behaviours without having conflicting information. So we've called, the DG has spoken about this many times, we call for open, clear, consistent communications at all levels. Everyone is responsible for this, from presidents to people on the street. We are all part of the information society. It is our responsibility to ensure that we pass on good information to others. We're all entitled to our opinions. Everybody's entitled to their opinion. But you must pass on good information to other people, not disinformation or misinformation.
Thank you. I would like now to invite Naomi O'Leary from Irish Times to ask the next question. Naomi, can you hear me?
Yes, I can hear you. Thank you very much for taking my question. I appreciate it. So I'd appreciate an answer from any of your experts, really. My question is, number of countries, particularly in Europe, are seeing a very serious surge in the virus. What are the new things that we have learned about the virus that we know now that we didn't know during the really bad surge in the spring that will help us this time to contain it? Thanks.
Thank you, Naomi. I think Dr. von Kerkhoff will answer this question.
So I could start. I would imagine many people would want to contribute to this because there's so much more that we know now than we did even in the spring. Mainly around sort of what works to prevent transmission, what works to reduce morbidity and mortality, reduce the ability for someone who is infected to developing severe disease, and reduce the amount of people who die from infection. And so one of the things that we continue to learn, and it may sound a little bit like a broken record, but the fundamental steps of being able to know where the virus is circulating, know who is infected with the virus, making sure that they receive quick test results, very quick test results, so that they can enter this clinical pathway and know and be assessed quickly to determine what type of care that they need. Individuals who enter clinical care pathways sooner can receive the life-saving care that they need. And those that have severe disease, those that have critical disease, can receive oxygen. We know oxygen saves lives. Those individuals who develop severe and critical disease can receive dexamethasone. And we know dexamethasone for severe and critical patients saves lives. And Dr. Janet Diaz is here with me who can comment on this further. But what we also know are ways in which we can prevent transmission from happening in the first place. We know that there are many ways that we could prevent amplification events from happening. One of the ways is for us to avoid these closed, enclosed, crowded spaces, close talking type settings, especially where we're indoors and there's poor ventilation. Opening up a window can help bring in fresh air from outside and bring the circulation of the air, improve the circulation of the air. We know individuals who are in close contact with one another need to stay apart. Physical distancing works. Hand hygiene works. The wearing of masks works. But again, we cannot be over-reliant on any one intervention. And this is something that has been worrying for us. In some situations, we do see an over-reliance on one particular aspect, one particular intervention. Even if you are wearing masks, you still need to maintain your distance. You still need to practice hand hygiene and make sure that your hands are clean when you touch the outside of your mask. You put on the mask appropriately, you take the mask off. You wear the mask over your nose and mouth. There are certain ways that these interventions need to be used so that they can protect you and protect your family. So there's a lot of aspects that we know around this. We know that cluster investigations help us bring outbreaks that seem overwhelming under control and break chains of transmission. And that workforce that is being built across the world needs to continue to be built. Not just health workers and frontline workers who are absolutely critical and essential to be trained and protected to care for patients. We need a workforce that can test individuals, that can collect samples, that can run the labs, that can carry out contact tracing, that can make phone calls to make sure that those who are in isolation at home are followed up on. For those who are in quarantine, are staying at home and receiving some follow-up and advice that they need. So those are the things that we know work, and that puts us in a very different situation than we were in the spring. So Jenna, I don't know if you want to comment on the life-saving work.
Thank you, and thanks for the opportunity for this question. I just want to echo what we know now, and we didn't know then, was really this COVID care pathway. We now know that early recognition of patients is necessary in order to apply the right isolation, which we know to stop transmission, but also to apply rapid diagnostic testing and rapid care for patients. We know the symptoms now, just not the typical symptoms, but we also know atypical symptoms of patients, so we can recognize them even when they come in with atypical symptoms. For severity of disease, we knew about pneumonia, we knew about ARDS and patients requiring invasive ventilation, but now we also know about the other complications such as stroke, cardiac disease, and other causes of thrombosis, so we can apply treatments for those conditions. And now, as Maria had already mentioned, we do have one life-saving treatment, and this is for patients with severe or critical COVID, so the use of corticosteroids, which reduces mortality. And finally, I just want to acknowledge what we heard from our guests that were here before, those patients that have had COVID. And I just want to say thank you for joining us. It is so important to hear from them and to understand from them, because what we're trying here is to save lives and to also reduce complications and hopefully reduce those post-COVID complications. And I think the best way to do that is to prevent transmission of disease and to prevent those hospitals from getting full. What we learned from the first peak was when the hospitals got full, the care got complicated. It is hard to care for patients, that many sick patients in an ICU. And so I think we have to remember that lesson and to stop transmission, stop patients from getting sick or getting very sick so that the health system can stay functioning and care for all patients. So thank you.
Dr. Ryan?
Just 2 points. I think what certainly we learned, and I learned in this last 10 months, is the absolute power of communities and societies to do things when they put their mind to it, when they come together. The incredible capacities of individuals to look to the care of others when they have the knowledge of how to do that. The tremendous courage of our health workers and others in doing that. But what I've also seen is a huge gap between rhetoric and reality, a huge gap between promises and practice, and at times a lack of follow-through, a sense of magical thinking. Enough, we've done enough now, this is going away. Enough already, we need to go back to our normal lives, and not following through and doubling down on the public health investment that's needed to put this virus to the sword, while we now, again, once more face the prospect of putting our society and our economies to the sword. We have got to learn from that. We have got to learn to follow through on this virus, collectively, all of us, because we do have the tools. And it's not just vaccines coming down the line. And Bruce, I would love Bruce to comment on this with his experiences in supporting Spain and Italy and beyond, but also on understanding that when vaccines do come, they will be a huge addition to our existing armoury. We are not using the tools we already have in our toolkit as effectively as we could. We'll be therefore misuse and not use vaccines as well as we could. So I think we have a few months now to really, really focus on what works. We have seen again and again across countries, within countries, that certain activities work. Bringing together a series of activities, both in healthcare resilience, in public health practice, and in community empowerment with government leadership. It's not rocket science. It works, but it requires commitment. It requires sustained commitment, hard work. It requires bringing people together and not tearing them apart. It requires humility, not hubris. And I wish the answers were simple and there was a magic solution. But like everything in our lives that's complicated, it takes hard work and commitment to work our way out of it as an individual or as a society. Bruce?
I think we've had a comprehensive and fantastic response from Maria and Janet and Mike. But I think one other point to Mike's suggestion that we've learned is we've learned what we're not doing right. And one of the most striking things we've seen in some of the most heavily affected areas is we're paying a lot of attention to the serious disease. We're paying a lot of attention or increasing attention to the contacts, but there's that bulk of the disease, which is in the mild cases and the moderate cases that are at home. And we're hearing, to the point Mike was making, striking data from surveys of these people that a substantial proportion, and in some places, the majority, they say, we do not remain isolated. We have to go out to get food. We have to go out to get medicines. This is some of the most striking and important things that we're learning, just the challenge to what Mike said of maintaining effective isolation of people with very little symptoms, if any, because that is the key. That's where most of the virus is. That is the key. If we're not managing that part of the virus, we're not managing this crisis. And the effective isolation of mild, moderate, and now sometimes asymptomatic cases is just so fundamentally important to being successful. I think the other points have been highlighted.
Thank you so much. I would like now to invite Michael Bousyor-Kif from CNN Opinion to ask the next question. Michael, can you hear me?
I can hear you loud and clear. Good to be back on. I've missed you all. My question kind of leads on the last one of what we know now, what we didn't know back then, and that comes to the question of quarantine. Many jurisdictions are really grappling with recalibrating quarantines. For example, one jurisdiction here in Canada wants to lower quarantine for returning Canadians to 2 days, providing they take a rapid test on arrival and 1-2 days later. Canada has some of the most severe quarantines in the world, 2 weeks, up to $1 million in fines and jail time. So there's pressure on the government to lower it. My question is this: can quarantines be safely lowered to, say, 5 days or a week? And are rapid tests, like the ones I described, reliable to slash those quarantine times? Thank you.
I'll begin, maybe Maria and maybe Jawad will like to add. Just to be clear, let us separate, because we use this word quarantine in relation to two things. There's the quarantine of people who are contacts of confirmed cases. And in that case, individuals should be in a quarantine situation in their own home or in another place for that 14 days. And WHO's advice on that is quite clear. You speak specifically about the travel process, and that is, in a sense, the quarantine of travellers who arrive in another country, or the restricted movement of travellers, or special arrangements, whatever countries call them, different things. And that is aimed at trying to prevent disease, number one, being imported, but more importantly, aimed at ensuring that an imported case doesn't generate further transmission, secondary transmission, or start a cluster. And the ignition of a cluster in a country very much depends on how much disease is already in that country. A cluster in a country with no cases is a disaster. A cluster in a country with hundreds of thousands of cases may not be such a disaster in that context. So I think everything here is looking at risk. And when countries decide on this quarantine of travellers, testing of travellers, they need to consider that there's no zero risk. There's no absolute test that will tell you that the person is going to be negative tomorrow or the next day or the next day. There's no completely foolproof follow-up plan that allows you to follow up those people for however number of days you choose to do that. And therefore it is a trade-off that countries have to make. The risk of a traveller arriving and potentially starting another chain of transmission against the obvious benefit of allowing travel from a social and an economic point of view. We can add testing and different measures into that. We are looking at that right now, and Maria and I and others were reviewing new guidance today, and I think we will be trying to create a little bit more specific and quantified guidance for countries on how to manage this. It is a difficult issue. What I will say is that the process of travel itself has been significantly de-risked. The travel industry, airlines, airports, authorities deserve huge credit. Travelling now is actually relatively safe. Your chance of being exposed during the travel process is actually relatively low because of all the measures that have been taken. That is not the problem we face right now. The problem we face is what we do with arriving travellers in another country. And how that risk is managed by authorities. And that's a decision, that's an active decision each country needs to make. How much risk are we willing to absorb? And how can we manage that risk? You do not know how to make that decision unless you understand what's happening in the country the person is coming from. And you will not be able to make that determination unless you know how strong your own response mechanism is. If you've got excellent public health surveillance, if you've got a really strong health system, you're able to monitor all the disease in your country, then travellers are going to be part of that system. If someone is coming from a country where you don't understand disease transmission and they're arriving in your country where you've got a very weak system, then the risks are much different for you and for that traveller. So it is a difficult issue. We are working with industry on it. I do believe the European Union and others are looking very hard themselves at how they can manage travel within the European Union and other places, other economic integration areas. And we will be coming out very soon with more advice for countries in terms of the risk management process. But there shall be no answers to this. There are no absolutes. This has to be made on a case-by-case, country-by-country basis, and based both on countries' capacity to manage risk and their appetite for that risk, their willingness to accept that you cannot have a zero-risk situation pertaining to international travel going forward.
Thank you.
Yes, thank you. I would like to comment more on the quarantine, the use of quarantine for contacts of confirmed cases. So this is not about the use of the word quarantine for travelers. So let me be clear. So when we talk about, you hear us talk a lot about isolation of cases, contact tracing, and quarantine of contacts. One of the things that's really important, and maybe it shouldn't be assumed, but contacts who are identified, these are individuals who had contact with a confirmed case either 2 days before that case developed symptoms up to the point in which they were isolated themselves. Those individuals, those people, need to be identified so that they can go into what we call quarantine. And this means 14 days of being separated from other people. But quarantine needs to be supported. And so I think we take for granted that when we say quarantine, that it assumes that people are supported through that period. The really critical aspect of quarantine of contacts is you've been exposed to the virus, which means that you have the possibility of having been infected. And if you are put in quarantine for that 14 days, we effectively reduce the possibility of you transmitting that virus to somebody else. Whether you have mild infection, whether you have asymptomatic infection, you break that chain of transmission. And so what is really important is if you are a case yourself, we have some of these videos out which describe how to do contact tracing and what it means to break the chains of transmission. If you are a case yourself, make a list of the people that you were in contact with in the 14 days before you got sick. Make a list of all of those people, all of the places that you went, and pick up the phone and make some phone calls. You should be contacted by a health authority in the area where you live, but if you're not, make a list of the people you came in contact with and make a phone call. Send a text message and say, I've been infected with the virus. I think you were a contact of me. I think you might need to quarantine. All of us have a role that we can play to support all of these public health actions. But if you are a contact of a confirmed case and you are in quarantine, that does mean that you need to be separated from people for the 14 days. And it means not going to work, and it means not going to the grocery store. So you need to be supported as you are in quarantine, whether people are helping to bring you food, making sure that you can telework, and that's what we mean by supported. It's easy for me to say be in quarantine for 14 days, but we know that that means you need to be supported through that, and we need governments to be able to support people through quarantine. The critical factors of breaking chains of transmission remain isolation of cases, all cases, whether you are severe and have severe disease, whether you have mild infection, whether you are asymptomatic, and the quarantine, supported quarantine of contacts.
Thank you. I would like to invite Dr. Jawad Mahtour to take the floor.
Thank you, Fadila, and thank you for this very important question. Just to add on what Mike said already, that we are working now on a new travel advice that we will share with countries to guide them on how to take additional travel measures to protect their countries and also to make the travel safe. And this new travel advice is based, of course, on the latest evidence that we collected, but also based on the IHR Emergency Committee that met yesterday, who advised us to continue using a risk-based approach in dealing with travelers and the risk in travel. Thank you.
Thank you, Dr. Mahsour. I would like now to give the floor to Peter Kinney from Anadolu News Agency. Peter, can you hear me?
Yes, I can hear you. We've had a lot of advice about how we should tackle this, and one of your mantras from the very beginning has been solidarity, testing. Now, in the two hotspot areas, America and Europe, North America, is there enough testing going on, and is it the right testing? Could you comment on it, please?
Yes, and Maria will come with some more specific data. I think the second part of your question is actually quite telling, and you can add this. You can ask this question about every country in the world: is it the right testing? That is the key. And are we using testing as strategically as we possibly can? I've seen countries with relatively low levels of availability of testing using that testing in a very strategic way, investigating clusters, trying to find out how disease is transmitting in the country, and then I've seen other countries use their testing, lots of testing, but not necessarily in a strategic fashion. So it's not about necessarily the amount of testing. But if you're in a situation in any country where you can't keep up with your symptomatic cases, where people who are symptomatic with COVID are not being tested, and you're systematically underestimating the size of the epidemic, then it's very hard to beat the epidemic in a situation like that, because you just don't know the size of the problem. So I would say, yes, testing is very important, but when, and Dr. Tedros has been quoted many times on saying how important testing was, but if you cast your mind back to very early in February and other times, he was also speaking about case finding, contact tracing, testing, quarantine, strengthening the health system, building community empowerment, depoliticizing the situation, working in a bipartisan and a all-of-government fashion. And I think that has been proven true time and time again in this response. No country has done it perfectly, but countries that have engaged in honest and transparent attempt to develop and support and sustain, and I use that word sustain carefully, sustain the effort over time, learn, investigate clusters, find out what's driving transmission in their own country, they've done well. They've done relatively well. And it doesn't mean those that have done well before will do well again, but they're doing relatively well in the response. Some countries were caught behind the curve. Some countries got disease early without the knowledge we have now. So we should not judge individual countries. In that sense, the real judgments don't come in the first wave of any epidemic, because nobody has all the information. The question is right now, we have seen this wave pass over the earth. We have seen approaching 50 million people infected, confirmed. We're seeing over 1 million deaths. The question is, are we willing to apply the learning? Many people have paid a heavy price. Have we learned? Yes, we have. That's not the problem or the challenge. The question is, can we apply the learning? And can we do that now as numbers rise again in the Northern Hemisphere? And I believe we can. So in terms of testing, yes, testing is important. Bringing in antigen-based testing and other tests right now is important, and Maria will speak to that. And that's what the ACT Accelerator and others in the diagnostics consortium that we participate in are trying to do. But please, testing is by itself is not the answer. It is testing plus everything else. Maria?
Thanks, Mike. Yes, I wholeheartedly support this strategic testing. We've seen so many different types of testing strategies all over the world, and it needs to be strategic because there are different types of tests that are on the market. The hallmark, the early tests that were rapidly developed early in January are still the mainstay, the PCR molecular-based testing. And the ability for all countries in the world to test for SARS-CoV-2 infection is incredible. It has expanded and grown at exponential rates across the world, not only using public health labs, but using private labs, using academic labs, and in some countries using veterinary labs. You know, there's been a mobilization of the capacity to increase for testing, but it needs to be strategic. And we have always recommended the testing of the suspected cases, people who are believed to have been exposed to the virus, who are at a higher risk of having that virus, and start there. And then through your cluster investigations, you can expand that to those who are in that facility or in that environment where that outbreak is occurring. So the PCR test, there are many on the market. There are so many countries that are doing these. And that has really advanced our ability to find the virus and who is infected. There are also these antigen-based rapid diagnostic tests, which get results back quicker. They get back in 15, 20, 30 minutes. They can be used. They're a little bit easier to use. They're cheaper, and there are many of these on the market. We have recently qualified 2 of these and are in the process of procuring them to supply to countries all over the world. But the antigen-based tests they don't perform as well as the PCR, but they work very well in several situations. First of all, they work best when there's a lot of virus around. If the virus is circulating in the community, they're able to capture virus, the proteins in individuals to capture somebody's infection. They work best when someone is most infectious. So when they have the most virus in their body, and this from the viral shedding data that we have from the research that's being published is about 2 days before symptom onset up to 5-7 days after they develop illness in that time period. They also are good for screening of health workers, for example. Health workers who are highly exposed, who are more at risk of getting infected with this virus because they're caring for COVID patients. And any situation where there's widespread community transmission. So these rapid antigen-based tests, which are cheaper, which are easier to use, which are becoming available more and more every day, can really help countries detect where this virus is and do these cluster investigations, as well as continuing to do the PCR tests. But again, as Mike has said, as we have been saying, it's not one measure alone. It can't just be testing alone. It can't just be contact tracing alone. It can't just be masks alone. It can't just be hand hygiene alone. We will continue to say that over and over again. But tests are a very important part of breaking these chains of transmission and bringing this pandemic under control.
Thank you. I would like now to give the floor to Stephanie Nebehe from Reuters. Stephanie, can you hear me? Stephanie.
Yes, please. Thanks very much. Fadela, a question then, please, specifically for Professor Didier Houssin, as chair of the Emergency Committee, if he's still available. Since we're a little bit in the dark about what the recommendations were, I haven't seen it yet tonight. I wondered if you could perhaps comment a bit on what specifically the Emergency Committee has recommended in terms of precautions for travelers or measures governments should be taking in terms of facilitating and screening and so forth. If you had any new recommendations on that issue of travel or anything else that has changed since your assessment 3 months ago. Thank you.
Thank you, Stephanie.
Thank you very much. 9 months after the beginning of the pandemic and after the declaration of a public health emergency of international concern, as was said by the WHO speakers, it's clear that we have learned a lot. So the recommendations made by the emergency committee have evolved over the time. And if you consider the differences between the recommendations we made between the end of July and this end of October, I think it's important to differentiate the recommendations which are directed towards WHO Secretariat, which has, of course, a leading role in the management of this pandemic, and the recommendations which are made towards member states as temporary recommendations according to the international health regulations. So these are defined into 13 recommendations on one side and 12 on the other, and I will not go into the detail because it would be too long. But I think that if I can focus on 2 or 3 main recommendations, I think the question of international travel is a very difficult question, and Mike Ryan explained very well the balance between the risk of traveling, not traveling, and the role the member states have to play in this. And I think it's very important that WHO produce an updated guidance with regard to safe international air travel. And clearly the use of the tests is certainly now supposed to have a much larger place compared to quarantine, for example, which would certainly facilitate things considering all the efforts which have been made by airlines and by airports. But of course, considering what the country can do on the side of the traveler, which is, I would say, from the starting point to the arrival point. With regard to member states, I think one very important point, because the pandemic is now 9-month duration, it's extremely important to avoid politicization. Of course, it's a bit of a naive vision because clearly, unfortunately, pandemic in some cases is used as a political tool for an opposition or for keeping power or reaching power. So, but it was our real responsibility to emphasize the fact that it's important not to use the pandemic as a tool, and that national unity should certainly be a major asset in the management of this pandemic. Well, these are 2 points which I can mention, but in the statement you will see more detail about the other recommendations which have been formulated by the emergency committee, and I use this moment to thank the members of the committee for their very useful contribution, and also, of course, the Secretariat for its excellent preparation of this emergency committee meeting. Thank you.
Thank you, Professor Didier Houssin. I would like now to invite Imogen Fools from the BBC to ask the next question. Imogen, can you hear me? Imogen?
Thank you. Now I have to unmute. Can you hear me, Fadela?
Yes, very well. Go ahead, please.
It's about China and the team, because you said that they had the first meeting, which is great, but it's virtual. I thought they were actually going to go to China. Do you have any update on that?
Hey, Imogen, how are you? Yes, that is definitely part of the plan, but it was certainly always part of the plan that the teams would meet virtually first. There's a lot of work already being done in terms of international and studies that have been carried out already in China. I think it's really important that the teams have opportunities to come together as a group, to look and review together what has been achieved so far, so that the trip, the mission ultimately will address the issues which are the gaps in knowledge, as opposed to going to the field and ending up repeating or not filling those gaps. So part of the process here is, number one, for the international team to become familiar with their colleagues in China, to exchange information on everything that has been done so far, to understand the outcomes of those studies, and then to plan the further studies that are needed. And we fully expect the team to deploy on the ground. And again, reminding everybody that it sometimes takes a very long time to get these missions in place. I cast my mind back to MERS, to SARS, and to other diseases in which it's taken months and sometimes years to establish animal origins, and sometimes years to get fully fledged investigations carried out on the ground. What we don't want is to end up creating some semblance that the studies are happening and everybody just moves on, and we create this idea. We want a full-scale, prolonged, sustained, comprehensive set of scientific investigations in China, in other countries. We've seen the issues with mink and with other animals potentially outside China, the potential for us to infect animals who can then infect us back. It's a complex issue, and we need to get the right answers. So I believe this is the method by which we will get the best answers. And that's what we need, is the best answers, not just any answer. That satisfies political needs of speed and the political needs of investigation. We are scientists. We want the best possible scientific outcome, generating the best possible evidence for the origin of this disease, because it's important. It's important that we know, but it's important that we know the truth. Not just, it's important that we do an investigation, and it's important that we build confidence between scientists, between governments, that this type of thing will happen again in the future. And we have got to build trust and the mechanisms that allow us to do this together. It is difficult to do this work in a politically intoxicated environment. It is hard for scientists to do what they have to do and want to do in situations like this. We are trying our best to ensure the best science in the face of one of the most devastating epidemics we've had to face together as a planet. We want to get the right answers, so we can take the best possible risk management measures into the future. We thank those international scientists, eminent individuals, for taking on that task to work on behalf of all science. We thank our Chinese colleagues, the scientists who've taken on that task on their side. We trust that this will be an example of how scientists, how health workers, and others can come together despite the divides that we see more and more in this world, to seek answers for the populations that we serve.
Thank you, Dr. Ryan. Just to let journalists know that the emergency committee statement is posted. It's on our website, and we will be sending it very shortly to our media list. Thank you. I would like now to invite Catherine Fiancon-Bolanga to ask the next question. Catherine, can you hear me?
Yes, thank you, Fadela, for giving me the floor. Today we had a very interesting press conference from Dr. Emma Hotcroft, who works for University of Basel, and she spoke about the fact that researchers from Basel and Spain have identified a novel SARS-CoV-2 variant. And she explained us that it was very important about countries sharing sequencing, and that it was not the case. So could you please elaborate a little bit on that and explain us the importance of sequencing, and also if there is a common platform, at least a European platform, to share that? Thank you.
I think that Dr. Swaminathan would like to take the floor.
So thank you for that question, and I think Maria will add to the interpretation also of the results that we're seeing. But I think it's a very important issue about sharing of genetic sequences, particularly from pathogens which cause epidemics and pandemics, and pathogens which have the potential to cause these, and to have a global mechanism for rapid sharing of the genetic sequence data is critical. And early on in January, we did have the Chinese scientists sharing the first full genome sequences of the SARS-CoV-2, which of course enabled labs around the world to start working on diagnostics as well as on vaccines. So there are global platforms that are public databases where scientists can deposit the whole genome sequences, as well as scientists can access, and scientists around the world can collaborate on many different aspects. And this helps us for many reasons, not just for diagnostics and vaccine development, but for tracking the epidemic. Because as viruses reproduce, multiply, they mutate. And so there are genetic signatures that get created as a virus over a period of time. And so this then allows also countries to use the data to see how many importations they might have had, how the first viruses came, from where they could have potentially come, how clusters happen, and also to track what's happening within countries also. So there are many applications now, and this is something that technology has really allowed us to do during this pandemic, probably which we have not seen in the past. We have several databases, including the GISAID database, which currently has over 170,000 whole genome sequences. There's also GenBank, and there is a European genomic data archive as well. But Maria might want to add, because there have been some recent analyses also about the latest variant that's circulating in Europe.
Thank you so much. Yes, there are, as Sumia has said, there are many countries that are sharing their full genome sequences for sharing them publicly so that they can be analyzed. I'm looking at the wrong, sorry. Thank you. And we need that to continue. We need researchers and scientists to continue to share those full genome sequences, because as we analyze them, as Sumia has pointed out, there's many things that we are looking for. These viruses change. They have mutations, and I keep saying mutations sound like a very scary word, but these are natural changes in these viruses. And what is important is that we monitor those changes to see if any of those changes mean the virus behaves differently. Does it transmit more efficiently? Does it cause more severe disease? Do our diagnostics still work? Will the vaccine that is in development still work, or has the virus changed too much? And what we're seeing is that this virus is relatively stable. It mutates on the more slow end of the spectrum compared to some other viruses, for example. And WHO, since January, in my team under an incredible doctor named Mark Perkins, with global scientists and virologists all over the world, have come together to look at the viruses, look at the full genome sequences to determine which changes are important and why. We will continue to see mutations, and there are more and more papers that are coming out that suggest, a new mutation here, a new mutation there, and that is to be expected. But what is important for us is to make sure that we have a group in order that can help us evaluate which ones are the most important and what are the types of studies that will help us determine if this virus behaves differently. So we not only work with the virologists, we work with phylogenetic experts that are looking at the differences in tracing these viruses in people to help us understand transmission. We work with mathematical modelers to help us look at changes in the epidemiology. So it's a multidisciplinary approach. But your question is a very good one. And if I can emphasize again, to continue to share these full genome sequences. We are in this for the long haul. So it is really important that we continue to monitor any of those changes. And while we do have, more than 170,000 full genome sequences available, we need more. And we need more from different countries. The databases that we have are really predominantly supplied by a handful of countries, and mainly high-income countries. And we have seen an explosion of effort to do full genome sequences in low and middle-income countries. There is incredible work that's happening in Africa with Africa CDC, the WHO in Africa, and other partners to build full genome sequence platforms in the African continent. We see that happening across the Eastern Mediterranean region as well, but we still need for that to continue. So thanks for that question, and please continue for the scientists that are watching us to share those sequences.
Thank you. We are up to the hour. Time to close this press conference. I would like to invite Dr. Tedros for his final words. DG, you have the floor.
Thank you, Fadila. So I would like to thank Paul, Marta, and Light for sharing your experiences and also for joining us today, and look forward to working with you closely in order to understand more about long COVID and address the issues related to that. I would also like to use this opportunity to thank our Emergency Committee Chair, Professor Didier Houssin. Thank you so much for joining and for your continued support and help, and through you to all members of the Emergency Committee. With that, thank you again to all those who have joined online, and look forward to seeing you next week. Have a nice weekend.
Thank you, DG. Just reminding journalists that you will be receiving the audio file of this press conference along with the DG speech right after this press conference. The full transcript will be available tomorrow morning. I would like to apologize to journalists I wasn't able to take questions from, but as usual, don't hesitate to contact the WHO media team. We will be happy to help you. Thank you and have a nice weekend.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.